Welcome to the House Appropriations Committee. It is Thursday, February 20th, 2025. It is just after 3 o'clock, and we are continuing our tour of the FY26 budget. And we're delighted this afternoon to have the Green Mountain Care Board with us. As I mentioned on the break, you haven't been in here yet with this committee and this biennium. So we will go around and introduce ourselves so you can meet all of us, and then we'll have you introduce yourselves and tell us about your budget.
Good afternoon. I'm Dave Yakovov from I represent the Lamoille, Washington district. Welcome.
Hi, Mike Nigro. I represent Bennington and Tom Stevens from Waterbury, representing the Washington Chittenden district.
Good afternoon, Jim Harrison, Chittenden, Mendon, Killington, and Pittsfield.
And Robin Shy from Middlebury.
Fifth Bloomley from Burlington.
Trevor Squirrel, Jericho and Underhill.
Wayne Rush, Highgate, Franklin, Berkshire, and Richford.
Mike Marucki from the Wyndham Ford District of Putney and Dummerston.
Hi, Lynn Dickinson. I represent St. Albans Town, and I just want to point out the vacant seat is John Kasanka, who is from Burke. He represents 10 towns in the kingdom.
The most number of towns of any district.
Larry Labor has 12.
Oh, he does, okay.
And two Gores.
Yeah. Two Gores. All right. So welcome and tell us about who you are and what you do.
Thank you, Chair Jai, members of the committee. It's a pleasure to be here. We always have enjoyed our opportunities to present to the House Healthcare Appropriations Committee. I'm Owen Foster, and I'm the chair of the Green Mountain Care Board. I've worked as a chair since October 1st of 2022. And I'll give an overview of the board and some of our work, and then we'll turn to the details of the budget that pleases the chair of the committee.
Hi, I'm Susan Barrett. I'm the executive director of the Green Mountain Care Board. I feel really old saying this. I've been in this position for 12 years.
Continuity's good.
Time flies.
I'm Jean Stetter. I am the Administrative Services Director for the board.
We brought somebody else with you.
Oh, yes, we did. Who would that be?
Introduce yourself.
I'm Diane Lambert. I work in the Green Mountain Care Board, probably the newest hire on this team. Right?
Welcome. Thank you. Is somebody online also? Did you see? No? Okay. Great.
First, the Green Mountain Care Board, for those of you who have not heard us testify before, we're an independent regulatory board. We're quasi-judicial. And what that means is we operate in a judicial-like setting. A number of the procedures we have are reviewing budgets for insurance companies, hospitals, accountable care organizations, and the like. Those are quasi-judicial in that there's evidence presented. We receive the evidence, we question witnesses, and then we have deliberations and votes, issue written, legally binding opinions and orders on the matters before us. We have 5 board members. I'll give you a brief background on who we are. So I'm a lawyer by trade. I was a federal prosecutor. My job right before this, prosecuted healthcare fraud, and I represented doctors in medical malpractice for the Justice Department. I investigated pharma companies, electronic medical record companies, the gamut. Jessica Holmes is an economics professor at Middlebury College, and she recently started a health economics program at Middlebury College. Member Lunge has been on the board 8 years, Member Holmes 10 years, I believe. Member Lunge is a health policy expert, has been involved in many of the state's efforts to improve our healthcare system over the last 20 years. She's departing the board on April 5th. So we don't have her for much longer. We're going to get every ounce of her between now and then. Dr. Merman started the same day as I did. He's an emergency room physician at Central Vermont Medical Center. And Tom Walsh is also a health policy professor and a physical therapist as well. We have staggered terms with the intent of being apolitical, and that not one governor will appoint all of us. Although at this point, Governor Scott has appointed all of us. Some of us twice, myself twice, I think Jess Holmes 2 or 3, no 2, and Member Lunge has been appointed 3 times now. So we are all Scott appointees at this point. I think 2 of them started with Shumlin, if I remember correctly. So the important point here is we're very transparent. All of our board hearings have to be in public. The public participates heavily in our processes, which is a great thing. And we don't answer to the administration. The administration does not have influence on our decisions, either through AHS or the governor's office. It's important to remember what we do and what we don't do. A lot of people sometimes conflate us with Medicare or DIVA or AHS. We do not control many facets of the healthcare system. We have a system-wide view, and I would argue that all of our decisions are interconnected with the rest of the healthcare system and have downstream impacts, which we need to be very cognizant of, but we do not directly regulate a lot of the system. We do not regulate federally qualified healthcare centers, independent providers, ambulatory surgical centers, other than certificates of need, out-of-state providers, mental health, long-term care, DAs. None of that is in our authorities. We also do not regulate or set Medicare or Medicaid rates. We don't regulate Medicare Advantage. We don't regulate self-insured plans or out-of-state healthcare plans. So we have kind of a small slice, but an important slice. And the focus of it is really hospital budgets. And there we typically review how much revenue they're bringing in, the cost structure, their expenses, how they're using their resources, and their amount they can increase their charges to commercial insurance. On insurance, we only regulate the qualified healthcare plans, and there only as to the amount of rate increase they can charge. So we don't regulate other insurance providers, and there's a lot of aspects of their work that might be covered by DFR or other regulatory bodies, not us. And then accountable care organizations. We regulate their budgets. And I'll talk a little bit about what we've done there to give you a flavor.
What's TCOC?
Yeah, good question. The total cost of care
Oh, okay.
under the states. Yeah,
I haven't gotten to the block yet. Thank you.
go to the next one.
Oh, sorry.
So I'll walk through some of the big, we do other work, data and reporting and policy work. So we have a number of annual reports that you'll likely receive that our team does. We also have a prescription drug advisory board analyzing how the state can begin to regulate potentially pharmaceutical prices. So that's work that is not regulatory in nature, but other things we do. So hospital budget review, we have 3 staff that work essentially full-time on hospital budgets. These are a huge part of the state's healthcare spend. State's healthcare spend is between $7 and $8 billion. Hospital budgets are about $3.7 billion of that money right now. And hospital prices and expenses associated with covering hospital bills is increasing dramatically in the state, and it is impacting the affordability crisis we have in healthcare. And to give you a sense of some of the decisions, in fiscal year 23, the Care Board approved the total amount of revenue the hospitals requested. But a couple hospitals went above that amount. There are very large increases. In this last year, we enforced the budgets, which I don't want to get too complicated, but it saved about $90 million-ish for commercial insurance. Hospitals went over by too much, and because of that, we reduced the prices that commercial insured Vermonters have to pay. Does that make sense? So if they go over the budget, we review it and we consider whether or not it was appropriate. And if not, it will result in a reduction in the amount Vermonters have to pay for commercial insurance. In fiscal year 24, we reduced hospital budgets by around $50 million. And in fiscal year 25, we reduced hospital budgets by about $145 million. And I'll give you a little bit of context as to why those decisions were made when I get to what I'll call the state of the state in healthcare.
Yeah, Lynn.
Just to clarify, when you say that you had $70 million that you reduced commercial insurance paid, is that paid for premiums by policyholders?
It's the level of rate increase that the hospitals would charge to insurance companies. So if a charge costs $100 and they want a 10% increase, it will now cost $110 in the next year. If we reduce the rate 1%, that amount will now cost $99. So it would be the charges that they charge insurance companies.
So it's what they charge the insurance.
Correct.
company. So
Correct.
you save it because they've got
Correct.
a lower reimbursement.
Exactly. And that can have 2 benefits. One, it can promote insurer solvency. Some of our insurers have serious insolvency risks, or at least one has very acute solvency risks, and they need to have adequate reserves to pay the claims. And so if you reduce the amount they have to pay, it gives them some room to put that money back in the bank, pay claims, or they can pass it along to their customers by not increasing their charges to customers as much. So I think that makes sense to everyone. It looks like I'm getting head nods. I'm going to go through this a little bit briefly because the ACO, the Accountable Care Organization, the state for the last 8 years has been in a healthcare reform effort called the all-payer model. And there's a lot of complication to it, but at bottom, it's an effort to improve healthcare by paying for healthcare in a different way. And we have a structure called an Accountable Care Organization. It's called OneCare Vermont. It's a subsidiary of the UVM Health Network. And they're a key feature in the all-payer model agreement. There's a cost to having that infrastructure. Annually, it's typically $12 to $15 million in operating expenses. And we hope that that investment in their operating expenses will result in lower healthcare and improved access and quality. The ACO model is ending at the end of this year, December 31st, it is over. The Care Board did a return on investment analysis to assess whether or not it worked or saved money. And depends on how you look at it and who you're saving money for. If there's one thing I think everyone should understand is when we talk about saving money, we want to make sure who we're saving money. Medicare, Medicaid, or commercial. Those are the three big payers in healthcare. And Medicare is obviously federal, and we pay part of that. But that's the one that we don't really care if we save Medicare that much money. We'd rather get more money from the feds and pay less elsewhere. Medicaid is for people with financial difficulty paying for healthcare, and the state pays about half of those costs through taxes, and then the feds pay the other half. And then commercial, our people and our businesses pay. Right now, we want to really focus on saving commercial as much money as possible because of our healthcare affordability crisis that we have. So in our ACO review, we have 2.5 FTEs that work on this. There's the big ACO, OneCare, and then there's 3 others at this point, maybe more coming. We review their budgets. We review them for compliance with their criteria to work in this state. And we've made some decisions the last 3 years that have reduced their budgets. We found that their administrative costs for them to operate were too high, and we felt that the money should be reallocated to care. I have a personal view that we spend too much money on healthcare bureaucracy and not enough money on healthcare. And as a state, I think my view is that's true. I say that as a healthcare bureaucrat.
On that particular issue, and not to get into the weeds of your purview and stuff, but there's a new group, Vermont Healthcare 911 or something, and they have talked in some of their newsletters or emails about that same issue that suggests that some of the Vermont hospitals are quite a bit higher than their peers. Do you measure that, and do you know where we fall?
Yes, we do measure it. And that's one of the drivers of some of those budget reductions in the prior slides. When we make those decisions about how much money to give a hospital in particular, we review what their commercial prices are. We review their clinical productivity. We review their administrative costs. We review their expense growth. We review aspects of their quality. And all of those things go into making our decisions. So if a hospital has a ton of money in the bank and has extremely high commercial prices, and we have a healthcare affordability crisis, the likelihood that they're going to get a large rate increase is pretty low. Now, if a hospital is geographically very important and isolated with a bad payer mix, meaning, so let me back up. Payer mix refers to what percentage of your money comes from commercial, Medicare, and Medicaid. The government payers don't pay as well, as much for a service as commercial. So if you go to like North Country, that hospital has what we call a weaker payer mix, meaning more government payer. So we might allow, because of their geographical importance and their payer mix, frankly, a higher amount of commercial charge than perhaps a different hospital with a larger percentage of commercial money and high expenses. Does that make sense? So I mean, we consider all of that. And I think that what you're referring to.
The ability to adjust their budgets by area. In other words, you need to cut $20 million and it needs to all come from administration?
We have not done that.
And
It's an open question. What we do is we, in our decisions, when we reduce a budget from what's requested, and when I say reduce, they've never gone down actually in total amount of revenue. It's from what is requested. We will point to areas in the budget where we think there's opportunity. One simple example is you have high utilization in your ED and low utilization in your primary care. You can move care from your ED to a more appropriate setting and more affordable setting for people, which is primary care. So we look at things like that and we'll highlight them in our budget orders to suggest, here's where you need to go.
And in fact, it's called the Budget Directive and Order or whatever you call it. And you can find it on their website. And I actually pulled down one earlier this year for the largest hospital just to see what it says. And it's very interesting. I mean, you guys do a lot of work to put those things out. I can see why you're quasi judicial. It's technical, but you learn a lot about how our hospitals are being run and where there's opportunities for improvement and where they're doing well. And it's very interesting.
Yeah, so I appreciate you saying that. Those budget orders are written and out the door for 14 hospitals in 14 days.
Yeah.
So
a lot of work.
our staff is really cranking, and that's at the height of summer for $3.7 billion of decisions.
Yeah.
So they really work hard.
Yes. And I appreciate it even more now, having read one of those.
No, thank you. They do great work. So on the ACO, I just want to flag a couple things. In fiscal year 23, we reduced their budget by $300,000 and we capped their executive compensation. This ended up going to the Supreme Court. The Supreme Court agreed that that was something within our authorities and we did it properly. And when Blue Cross departed the OneCare program, we ordered OneCare to make sure they paid primary care the same amount of money as they were planning to before Blue Cross left. There was going to be a shortfall of money and we said, no, you've got to comply with this and pay the full amount. That might seem like a small thing, but it's actually a huge value add to the state that we did that. Primary care is in a difficult spot, and that amount of money really helped maintain primary care for a number of those practices. It was, I forget the amount, it was a couple $1 million, but a couple $1 million for struggling primary care is a big deal. That was a really important decision that I don't think people really recognized other than we did. Fiscal year 24, we reduced the budget from OneCare by $1 million. And again, we ordered reallocation of those funds to population health and primary care programs. Again, reallocating money to support primary care and others. And just this last year, we did the same thing again. We said this budget is too high. We're reducing it by $1.5 million. And again, reallocating those dollars to improving primary care, mental health, and long-term care, areas that are struggling in our state to survive financially. Insurance rate review. This is for about 70,000 Vermonters on what's called qualified healthcare plans. We have 3 FTEs that work on that. Insurers requested approximately $150 million in premium increases, the amount Vermonters will pay in more premium dollars. This last year, we reduced that $150 million by $11 million. And some of it was based on actuarial analysis, and some things were a little high here, some things were a little high there, but we approved the lion's share of what was requested. And I think that's a really important decision to make. It's a lot of money, but Blue Cross is facing insolvency. And had we reduced that more, I am not sure how long they would be able to survive. And so, yes, we approved a lot of money, but I think sometimes that's the right thing to do. And this is an example of that. Previously, we had reduced Blue Cross's budgets fairly consistently, trying to promote affordability for Vermonters. That did lead to an administratively efficient operation. Blue Cross is run administratively rather leanly and pretty well. And I think that some of our decisions maybe had an impact on that, maybe it was their own great work, but it also reduced their reserves. And that's part of where we are now. We're having a spike in utilization and healthcare costs, and the reserves have been brought down to a place that is not sustainable.
Question, you're gonna call on me, I kind of forget, all right, what? I'm just curious, we keep hearing about utilization rates, how they've affected
our global commitment, here, in many of the departmental budgets. And I'm just wondering, how do you understand the utilization rate increase?
It's a really complex thing to understand. And it depends on the hospital, and it also depends on the service. So it can change kind of across the state who's having greater increases. There's also acuity. Acuity matters because it impacts how much money you get paid, how sick is the patient. And that can be a billing thing or patients being sicker or whatever it might be. So those things both tie in to increased insurance premiums, right? So the driver of it, it's hard to pinpoint a driver of increased utilization acuity. But if anything, it tells us what we're doing as a state is wrong and we're not doing it properly because we want improved population health. And if where we're spending our money and how we're doing it, it's not resulting in lower utilization and lower acuity, we've got to really reconsider what we're doing.
And then Rebecca Vine.
On the same line of thinking. Must be, you can look at and see, what categories of care or problems that people have that are contributing to the greater utilization. Where is it coming in? Does it tie into anything else that we know that's going on in the state in terms of anything from drug use to whatever that's going on in the state, and how does that compare on a nationwide basis to other hospitals across the country that aren't in the same kind of problems that we have? Are you looking at those kinds of things to find connections?
Largely not. So, I mean, our hospital staff is 3 people and reviewing 14 budgets that are this big with data. We don't get into, in 3 months, we don't get into that kind of granularity. We do look at the increases, but we don't do some sort of breakdown versus national of this hospital. I mean, that's a lot of work to get into. So I don't think we really have a finger on the pulse of what service lines at which hospital versus national.
And no other organization does?
I don't believe so.
We're kind of shooting blind.
We do it at a high level, right? So we will look at utilization. If that's a driver, that might impact whether or not we say yes or no. But a lot of it really goes back to expense control, expense growth, and provider productivity, those kinds of things.
If we have a trend in the state that's different than other states that is causing the care, or what you have to, either the volume of care or the elevation of care to change within the hospital, that's driving us in a certain direction. Understanding that so that we could take some outside corrective actions might also help.
Agreed. So the payers, we're not a payer, would probably have that data and information. So Medicaid would know where their claims are coming in and what they're paying for. Medicare would have that information, and the commercial would have that information. I think Blue Cross has testified as to some of the drivers they're seeing. There's particular hospitals that I've reviewed their budget more closely last summer, where we did see an increase in CT and MRI and X-rays, but there had been a backlog. So some of this could be trying to improve access. We have delays in getting care. So is it that we're doing a better job of increasing access and that's driving utilization? I mean, they're really nuanced questions that our team of 3 in 2 months is not going to get into.
Wouldn't the hospitals, when they present their budgets and their CONs and the different things, would be able to pinpoint to things trends that they see within their hospitals as you're interviewing them as part of your review?
Yeah, there will be things, but I mean, anecdotally, it might be, well, we're seeing more xylazine wounds. Okay, well, there's a whole lot else you do, right? Are we seeing more knee replacements? We know I know that UVM is seeing more patients for X-ray and imaging because of something that they presented, but there's 100 other things that are going on and that they're doing. So yes, we do get that information at sort of what I'd call a high level, but to kind of drilling down an analysis across service lines, across hospitals, across the country is not within our bandwidth.
Has there been any discussion about the demographics? I mean, the older you get, the more likely you are to need care, the more
for sure
intensity. That's part of the.
For sure, that is definitely relevant, right? I mean, we are an aging state. That is true, and the older you are on the older side will lead to more care and greater acuity. Is that the driver? I mean, these are really hard questions to answer. this is it. It doesn't really exist as an answer.
From where you sit, you indicated you have a system-wide view. Though you don't regulate all of healthcare, you still look at the whole system, correct?
Correct.
If you were sitting in one of our seats and you were hearing from your constituents that to the degree that it felt like they were imploding, long-term care is struggling, home health closes, hospitals thinking of cutting back services, not enough primary care, insurance company, if you heard all of that, but you were sitting in this seat and you wanted to do something, what would you focus on?
It's a great question. And I would say what your constituents are telling you, it is accurate. It's true. What I would say is that the state does need a statewide plan for how we're going to allocate our money and how we're going to use our money. Right now, it is very siloed. We look at hospital budgets and part of an insurance company. What's happening with the DAs and everyone else is not in our regulatory process. We've taken a lot of effort to bring that information in the last few years so that we are being better informed. Because if we give a hospital 10, 20% rate increase, that will help that hospital for sure. But it will hurt the insurer, it'll hurt demographics, it'll hurt affordability, it'll hurt the small business and economic growth, it'll hurt long-term care and everyone else you mentioned.
Given so much seems to be hemorrhaging, would we be wrong to focus on primary care?
You would not be wrong to focus on primary care. I think right now, my view is we are in a state where we need to identify what's really at risk and then make priorities as to what we need to maintain and ensure we have. So local emergency care, urgent care, we need primary care in every community, mental health and long-term care. We're also aging, so we have the memory care that we need. We have the services we need. We need to prioritize the care that we have. You're going to be losing services. There's no sugarcoating it.
Sorry, I came in a little bit late, John Kosenska from Burke earlier. And just to follow up to what you just said there, do you have a sense of the types of services that may end up being lost in some areas of the state? I'm not trying to pin you down with the hospital here at all, but we talk about that often.
Yeah, good question. So I think that there are at least 3 hospitals at risk in the next 2 to 4 years. So Oliver Wyman did a study, part of Act 167. That's what they concluded. Becker's put out a report totally unconnected to our state, and we were one of the states with the most hospitals at risk of immediate closure. So there are hospitals that are at financial risk. They simply are. How many, how long, so much depends. What are the federal changes that are coming down the pipe, right? Those can make that problem happen real quick. In terms of, I think if you're going to maintain our hospitals, we're going to need to make some system-wide changes on the services that are delivered, where they're delivered and how they're delivered. And you also need to make sure that the systems around the hospitals are protected. When things back up in hospitals, it hurts hospital finances. So the primary care example, mental health example. So you need those. Frankly, I think nearly everything is at risk right now. I think mental health, long-term care, hospital care, primary care, FQHCs, insurance, they're all in deep trouble. I think that you do need, to represent the Acaboni's question, you need to prioritize and protect what you got to protect.
Rep. Dickinson and Rep. Stevens.
So how did we get here? I mean, I look back when David and I were on the POC together 20 years ago. It's been a while. We were told we had the lowest healthcare costs in the country, or very close to the lowest, if not the lowest. And everybody still thought it was very expensive, and everybody tried. And since then, we got this Medicaid 101 beginning of this session, and our Medicaid is increased by about 50%, and as has Medicare, because it's a government program, and we're obviously getting older, so more people are using it. But we went from commercial insurance of 60% in 2008 to 49% of 2021. Now, I don't see that as an indicator of a healthy economy, because the more people you put on Medicaid, the more pressure it puts on your commercial insurance, because it doesn't pay the full amount. Someone's got to make up the difference. So your premium costs go up. The hospitals many times can't recoup everything. So it just has And we've put a ton of money since then into all kinds of reforms, including what you guys do. Although we used to get paid $50 a day with a free lunch at the Capitol Plaza, but anyway.
Different times.
Well, we were an appointed board that didn't do anything. We just came once a month. The point is that we did a lot of, maybe we didn't do it all. We didn't make a decision. But we were the oversight commission and we heard all the same kinds of stuff you talk about now. But, you know, I look at it and the way the insurance has changed as an employer, we've gone to where we went from, pre-ACA, $1,000 or $500 deductible to $2,000 to $3,000 to $5,000. And it balloons. And I'm just wondering, you know, people complain because they have to pay so much out of pocket, which is true. And I'm just wondering if maybe we should be just looking at a major medical insurance that wouldn't be any different in cost to what people pay out of pocket. Or we should look at maybe what we've done, we've increased eligibility for Medicaid, but we've reduced what we pay the providers instead of putting more money in. And, you know, the nursing homes have always had a problem with us because they can't cost shift to anybody, but very little people. So how do we get out of this? What do we do next?
So
Right now.
You know,
You only have till 4.
that is right now. So, how do we get here? I mean, so let me take a couple things. So your point about decreasing number of commercial payers is really important because, so I'll give you an example. So Medicare is supposed to pay about 100% of what the costs are to deliver care. That's their goal. Medicaid probably covers around 60-ish% of the cost of care. And then commercial makes up that gap. So the national average for a percentage of Medicare is about 250% for hospitals. We have some hospitals that are more like 320, 315, higher than that. So very, very high prices. And I think that's what Representative Harrison was alluding to earlier. Meanwhile, we have all these other systems that rely just on Medicaid, right? Like the nursing homes or mental health, right? And they can't do that. So we need to fix who we're paying and how. So we want to move primary care out of the hospitals to the extent that we can because it's more affordable and they don't send all the referrals to the most expensive place, whatever it is. But we pay the most and you make the most at the hospitals, right? So we're doing it wrong. We don't put our money where our values are. We don't put our money on mental health and long-term care. We rely on Medicaid and Medicaid doesn't pay well enough. We're not doing what we say. That's the problem. So I think that right now, you also can't disrupt the hospital system. That would be chaotic and terrible. You need to maintain what you have outside of the hospital and within the hospital as well as you can for a little bit of time. Like that's step one. You can't have everything get consolidated into a hospital-based healthcare system. That's kind of what we have. We have an overwhelmingly hospital-based care delivery system. And that's not fair to hospitals. They can't do that. That's not their job. It's way too expensive. So you need to maintain the things around it as well as you possibly can. And that's why some of these decisions I'm citing, that's why we did that. Why we put the money towards mental health rather than the ACO, right? So that's what we were trying to do. When we've been reducing hospital commercial increases, the goal was to ensure that Blue Cross could have some money to remain solvent, but also to pay those other providers more fairly so that we don't lose them. That's what we're doing.
I had Rep. Kuchenski and then Rep. Stevens.
So just real quick, so if things moved in a direction where primary care moved out of the hospitals, what happens? How does the hospital continue their service to the community? What would that look like? And I don't trying to come down to a number or anything here at all. It's just
So
as we're talking about this.
Yeah, some providers won't want to not be associated with the hospital, and some communities can't have that. Some communities are going to have the hospital provide primary care. But you want to maintain it outside of the hospital to the extent you can. The impact to a hospital would be that a lot of them lose money on primary care. So it actually might be financially beneficial, but for the referrals they get from their own primary care for surgeries, it might be a higher dollar value. But if you shift how you pay and you end up paying more for primary care, that calculation might shift a little bit. So I mean, hospitals will be fine. There are many hospitals that don't provide any primary care. That won't necessarily break the bank. Might even be beneficial in some instances.
So I guess just to follow, just a quick example. I mean, you know, the St. Johnsbury Hospital there, we have our hospital, we have a couple of clinics that come under the umbrella of all of that.
Right.
So they're not like actually in the hospital here per se every day. They're at their other location here. That's where patients come to see them for checkups and all kinds of, you know, vaccine kinds of things and other
Right.
follow-up kinds of things. And then if for some reason they become ill and need to be admitted to the hospital, that's the connection right there. So do you see, and there's other communities where that's probably the case as well. I'm not versed on all of the specifics of every hospital area here in the state, but how would that, so would an area be able to maintain what they currently have to some degree? We know change is coming here. We're not naive to that, but.
Yeah, I mean, the goal would certainly to maintain primary care as well as you can in every single community. You're not going to flick a light switch and all of a sudden primary care moves out of a hospital.
Of course not.
But if there are places like in Chittenden County, it's an easier example because there's much bigger population. There are a number of independent primary care providers and FQHCs around. You don't want to lose those. So what I'm really suggesting is in the short term, we want to make sure that those remain solvent and available. If those go away, if community health centers in Burlington, which is having financial trouble, goes away, a huge number of patients all of a sudden back up in UVM's ED. And that really hurts UVM's financials and the state's financials. So I think that's really what I'm saying is trying to maintain what we have outside of hospitals because it supports hospitals.
That's helpful for me to understand that.
Yeah, it really is an interconnected system. One domino falls and you have major impacts across the
And the rural parts of the state are just very different.
Entirely different.
Geography and population.
And yeah, the ability for an independent provider to open up shop at St. Johnsbury, yeah, it's different, right? Or up in Newport, it's different. Rutland is a different scene than Newport, and Burlington is itself as well.
Thank you.
Yeah, no, good question.
Let's continue.
Yeah. I like these committees when you get a lot of questions. These are really good. This committee has always had a lot of questions.
Yes, yes. Well, when you hold the purse strings, you really do.
I was hoping with a change in chair.
You know, it's interesting. We started the day with public education and now we're ending with healthcare. So we're having quite the day.
Can we skip this one? I can probably skip that. This is a little bit of the state of the state. Would you like this, Chair, just so people know? I mean, you kind of get that it's doom and gloom, I think, but.
But here's the visual.
The slides will show you. So national news is paying more and more attention to our problems in Vermont and our healthcare. And a big piece of it is our healthcare costs are some of the highest in the country, if not the highest, and they're increasing the most rapidly. So if the rest of the country is going up 5-6%, we're seeing 10, 12, 20% in Vermont. And that just will not continue to work. We talk about property taxes, but the healthcare taxes and that health insurance premiums are a tax. They're a tax on your businesses and your people. They just are. They're the same thing, even though we think about them a little different. So our costs are going up the most, and they are already some of the highest. Go ahead. This gives you a sense of what that looks financially to a family. On the left is the premiums for a Blue Cross plan for a family of 4, and then the out-of-pocket. And you can see it's close to $50,000 a year for a platinum plan for a family of 4 on Blue Cross, or even for a silver plan is nearly as much. And then you have the out-of-pocket on the other side, another $15,000. So you're talking enormous healthcare costs. On the individual plan, you do have subsidies right now, which for a large swath of these people help minimize the cost that hits the family's pocketbook. Those are set to sunset at the end of this year, and it's to be determined if they'll be extended. If they're not extended, these costs become instantly very, very, very real, and a lot of people will just go off of insurance entirely.
And that's the problem.
Do all of the subsidies disappear?
All of the federal subsidies are set to sunset. But they could continue part of them or some of them, or we don't know what they're going to do yet.
The ACA, the underlying ACA will stay.
Yeah, the ones, the COVID expansion will go away.
Okay.
The magnitude of the difference between Vermont and seems so great. I would think that any competent analyst would be able to stumble over the reading of what's driving this.
Yeah, that's easy. It's pharmaceutical prices, it's hospital prices, and it's increased utilization. I mean, we know what's driving it. What do you do about it? Do you tell people you can't take the pharmaceuticals that you need? Do you lower pharmaceutical prices? Do you lower hospital prices? I mean, the drivers are not the mental health care. It's not the long-term care. I mean, that's going up, but it's really concentrated at pharmaceuticals and hospital expenses.
Choices. Somebody's making choices.
So what do you mean by that?
Well, if they're not going up because of some fixed cost kind of thing, then somebody has to be choosing to do something that is different than the rest of the country in order to drive the costs.
So there are a lot of fixed costs that are associated with our increases, and there's probably some level of our fixed costs being greater than elsewhere because of geography, volume, all those things. I would accept that we probably are fixed costs a little bit higher because we're rural. Rural is different just across the country. And then
Shouldn't go like that.
no, it shouldn't.
I just want to put my 2 cents in here because I think you recognize or sharing what are the drivers here. And when you look at pharmaceuticals, what they cost in this country, and then what they cost just above the border or in Europe. I mean, they're talking to do us. There's no other way to look at it.
Can I speak a
Certain
bit?
things are cost, I think you're also thinking about individuals, but we have there are certain chronic things that are much more expensive. Diabetes and, things like that are different than, and then we've got Jim and John.
We could spend a lot of time on this.
Yes.
And probably none of us here, on this side of the table have the answer, so we appreciate the opportunity to ask questions of you. If you were to look at these last couple of charts and we see how Vermont's significantly higher than national average, how do we compare with and I get it, we're rural, we're small, we're always going to be on the higher side. How do we compare with Maine, which is even older than Vermont? Or how do we compare with the New Hampshire, which I suspect is also in the top tier with average age and also rural? That's the things that I think we need to be comparing ourselves with, as opposed to the US average, which may be, really not pertinent.
So the answer is poorly. We compare poorly to other age states.
And that I can't accept being higher than Maine. Maine is probably more rural than Vermont because they're twice the population, but they're significantly larger geographically. And they're older. And that's the excuse that you keep hearing, whether it was the consultant study, the aging demographics are a cause of our problem because old folks like me need more healthcare. I refuse to accept that if other states are doing better in terms of an affordability.
I agree with you. And we do have I didn't put it in this deck. We do have slides comparing us to New Hampshire and Maine. New Hampshire and Maine are, I think, the first and the third oldest. Maybe we're second, somewhere around there. And we compare very poorly compared to them. We need to change our system of care. That is why the state did the Oliver Wyman report, and now we need to make some changes. We can't sustain. So look, here's what happens. If we say no to a hospital budget, so let me back up. What can you control? We can't control pharmaceutical prices today. We're looking at it. We're going to try. The state allocates some money to look at it. That will be 3 or 4 years before it happens. And then we'll get sued to high water and we'll see what happens from there. So we're not going to control pharmaceuticals. You're not going to control the price of them. You're not going to control what they take, right? People are going to take them. So forget that. That's just going to be what it is. Then second, you have hospital utilization. What are you going to do? You can't go to the hospital. You can't do this. You can't really control when people need to go to the doctor. Third, acuity. You can't really make people get healthier or tell hospitals don't bill for the level of acuity. Fourth, you have hospital price. That's the one you can control, right? And that's not all of the problem here, but that is a problem in this state. Our hospital prices are too high. Then you have the non-hospitals. And as we said, mental health, a lot of them are on Medicaid, and that's not your problem on this graph either. So the only thing you can control really in all these is hospital price. When we reduce hospital price, there is an uproar about what it will do to hospital solvency. And it's true. I bet every representative with a hospital in their community does not want to see their hospital have financial problems. But you can't have it both ways.
Looking at the insurance thing.
Oh, you're on a different slide.
Well, I'm looking at this, I'm a little ahead of you. But yeah.
Okay.
Well, two things.
Go ahead.
Two things. Looking at the days of cash on hand. An important criteria that hospitals look at, because it's a bonding issue. I mean, schools look at it. A lot of people look at it. It's going down precipitously. This is part of the reason the hospitals are having the insolvency. This is a symptom of the insolvency.
Correct.
Can you talk about what that is, what that means?
Yeah. Go one first, Jean. I think this is also relevant. So the insolvency, as I said before, is not just the hospitals. There are insolvency risks there, but also Blue Cross. So Blue Cross, the Department of Financial Regulation range is, I think it's 590 to 750 RBC. That's the measure of their reserves. And they're supposed to have 590 to 700, which is in this chart. And percent, it's a percent, but it correlates to dollars.
Yeah.
In any event, you can see from 2021 to 2023, the steep decline in their reserves because they're paying out claims. They have to pay for the claims when the people go to get the care or the drugs or whatever it is. And that 337 in 2023, that has dropped enormously in the last year. That would be a steeper line down, right? Blue Cross is not able to pay claims. The entire system falls apart. People can't pay for it. The hospital won't get paid. No one will get paid. It'll be a real problem. So that's important for everyone to know. And if you go to the next one, Representative Dickinson's question on the hospital days cash on hand, Representative is correct. It's one of the main things that we look at for financial health of hospitals. And you can see also that that's been declining. So we're paying more and more and more, hoping for solvency and access and to not lose a hospital. And it's not working because Blue Cross is going broke and the hospitals are declining significantly on this. There's some noise in here and that some hospitals are really good. Some have like 200 plus, which is probably too much, frankly, in this time. And then there are others with 40, 50, 30 days cash on hand. Real acute financial trouble. Then you go to the community providers, the DAs, like Howard Center, I think has 5 or 6 days cash on hand. Little Rivers, the FQHC might be 5 or 6. Lamoille might be less. So it's everywhere. It's everywhere. You can't pay your way out of this problem. So you need to make changes and we need to accept that that's going to be where we're at.
Your priority.
So what level of cash on hand would be ideal?
Yeah.
Just thinking about, some have for a few days, some have 200. Which
So-
isn't necessarily a bad thing here, but it's just,
No, so for a hospital, we kind of like to see, sorry.
no, so those that have more cash on
Yeah.
hand may not see that year to year.
Right, it can move depending on how the year goes.
Right.
I mean, not too much movement.
Some things happen when they gotta pay for things. So
Yeah, so a healthy range, we kind of like 125 to 175. 150 is pretty good. 140 is not bad. 125 is not like alarm bell. 50 is really concerning because that can go real quick. Like when Springfield went bankrupt.
Yeah.
Goes fast.
Yeah, it does go fast. Thank you.
So what do you do about this? We can't raise commercial insurance costs and we can't raise I don't think you're going to raise Medicaid. And I don't see the feds pouring money on us. So you have to deal with that reality and make the changes you need to make to protect the care that you have to have.
Okay, let's keep going.
So I did want to connect this just so everyone understands that. So these healthcare costs, it's not just insurance premiums, it's also the state of Vermont and the teachers. So a lot of talk in this building about property taxes and taxes in general, appropriately so. This is a graph of the state of Vermont healthcare costs. State of Vermont has a fund that it pays for claims out of reserves. And here you can see the rate increases for premiums for the state of Vermont. It was 7%, 11%, 14.4, 15%. When the state has to pay more in premiums, the state has to take money from somewhere, whether it be taxes or another part of the state's budget. Despite paying more and more and more in state healthcare costs, The state healthcare plan last year lost $40 million.
This is not teachers, this is state employees.
State
not
employees.
teachers.
So $40 million loss after what, 30% rate increase in 2 years.
And so this is why we did the 18.5 million in the budget adjustment, capitalizing the expenses, so it would not be such a dramatic hit to say.
And that's a self-insured plan.
Yes, it's a
This is-
supplement.
Without paying premiums to anybody.
But again, they've also had acuity utilization, and you have a couple of serious cases of illness. And, we've all heard those stories of how much that can cost.
The next slide, briefly I'll touch on the teachers. This is the Vermont Education Health Initiative. This is the teachers union and their premium increases. Again, you can see other than 22, it's about double digits every single year. Double digits every single year is simply not sustainable. And they are also losing money on their fund. They're self-insured as well. And they're also down millions and millions of dollars despite increasing their premiums pretty significantly.
And this shows up in our property taxes.
Yes.
Because this is in the education fund. So when you talk about healthcare being a tax,
This is in property taxes. So school budgets are strained as they pay 10% more every year. So they either provide less of the services that we want them to provide for our students. This eats into their budget, or they raise property taxes. Healthcare costs are one of the biggest drivers of increased education costs and increased property taxes. So you need to abate this problem if you're going to address those.
Okay, 3 years ago, the teachers always had a very generous policy. And the Cadillac penalty went into effect. I don't know if you were around in those days, but Green Mountain Care was around. They saw increases. I'm not sure so much the teachers, but I think the parent educators, the support staff. So do you know what year that was in relationship to this? Or
I don't. I'm sure we could find that
it was
out.
a Cadillac that was being penalized by the ACA?
I don't know what year that would have been in this chart.
I think it was before this chart.
Yeah, but since then, of course.
I think it would be before.
Yeah.
so we're kind of running out of time. And we can have you here all day. This is another one of those passionate subjects, but we.
I'm going to make them go first.
We need to look at your budget.
So actually, that's an opportunity for a segue because Chair Shy referenced Commissioner Fastucci coming in to testify for the BAA about backstopping the fund. You see this every single day in our budgets all across state government. You see the increased cost, that every single department that comes to you is bringing forward. And one of the things, going back to what Chair Foster was saying, is one of the cruelest of ironies is one of the, and correct me if I'm wrong, because I'm not a policy person, but one of the things that is really driving the acute financial crisis for the FUHCs and all these providers is their increased healthcare costs. So
For their employees.
please, for their employees. So sorry, let me know if I misstated that. I'm gonna jump. Chair, I wanted to make sure I heard you'd like us to jump ahead to our ups and downs.
We have to really need to be done by 4, which is like in 2 minutes. We have
Okay.
a public hearing and we need to get set up for that.
Okay.
So that's why.
Oh, public, yeah. Oh,
We have a public hearing.
I didn't mean to say this so loud. So,
And it's our fault because we have lots of questions and you're so good at answering them. So thank you.
I will be very succinct. So this summary, what this does is this shows for just the base Green Mountain Care Board without the governor's base initiative. We are up a total of 5%. And again,
I hope you're not blaming that on health insurance costs.
well, I was going to say that salary and fringe is up the highest amount. So, but that means we have to find it from somewhere, our increase doesn't cover all the things. I broke out Act 134 separately. This was enacted last year, which is a separate funding stream through the evidence-based advertising fund for 2 employees to investigate and look at what Chair Foster referenced, which is the potential for regulating prescription drug. That's work that the legislature gave the board. That wasn't part of the big bill last year, so it's broken out separately. The governor-based initiative, so the governor and the administration, they granted us $750,000 of mixed funds. So that's $300 general fund plus the ability to match with our bill back. 3 pool positions and, potentially some contracts, which was part of a request for more staffing. I want to quickly move right here to, before I go there, I just want to say, in general, the Green Mountain Care Board is funded 40% general fund, 60% bill back, which is what that means is we charge those entities we regulate for the pleasure of being regulated. So the change this year is the addition of the very focused prescription drug work. I should say these 2 employees aren't available to the rest of the board. They're just focused on their thing. There's been a lot of talk about the AHEAD model. The board voted to approve AHEAD going forward with some conditions. One of the conditions is that we need 5 positions by 5 new positions by the beginning of September. And then we also need additional positions after that. So if the budget just goes through with the 3 positions that we have in the Gov base, then the board won't meet the conditions for the AHEAD model, and that will trigger a no. That's a whole separate kind of conversation.
Yes.
But I'm going to keep moving through this, if that's okay.
Yes, but I just want to say, I thought I heard that staff at the AHEAD program at the federal government, are they still even there?
That goes to, we have that categorized here as unknowns,
Okay.
which there are many.
But there were 3 staff who were let go, but
Yeah.
there's still staff.
There are still some staff, okay. Okay.
So one thing that I am going to very quickly buzz through this. One thing that we would like, but it's not part of the GovRec, is looking at just very short-term limited service positions, more like right out of college data people, to do some automation. We do a lot of reports, and we have these great people that we hire. They see so much opportunity for getting rid of rote. You're reinventing, you're doing the same thing. That was a pitch I just wanted to say. We do have a language change. This is related to One Care Vermont ending its service. I want to be clear, the language change here is changing how our main bill back statute, the 4060, is allocated. So this is the 60% right now.
With the ACO going away, you're changing it, but didn't we put that in a budget adjustment?
No, it's right here.
So I know that.
No.
Then we've seen it in the budget then.
Correct.
I've seen
You've
it.
seen it in the budget, not in the budget adjustment. So this is just talking about the 60% that's allocated. So right now it's hospitals, insurers, and the ACO. Since the one big ACO is going away, we are requesting a change. Now, there's separate work being developed, S63, which has fees for ACOs, some changes, because there's Medicare only ACOs. But for the 60% allocated, so if you have One Care Vermont going away and an unknown number of Medicare only ACOs, it does not make sense to have a set fixed percentage in statute for what the ACOs need to pay. So we propose reallocating those costs, which last year would have been a little under $570,000 between the hospitals and the insurers. Now, you'll see in the language, we heavily weighted it towards the hospitals because the hospitals are currently paying fees to One Care Vermont. So that's why we did it there, and we did a small percentage to the insurers for some fairness. Now, if S63 passes and we have fees there for, X number of dollars for a review of Medicare only, X number of dollars for a budget review, X number of dollars for like an annual recheck. If that goes through, those fees that the ACO, Medicare only ACOs pay will reduce the amount of 60%. So we're not double dipping, if that makes sense. So
S63.
S63.
Yeah.
And the last thing is the unknowns, which is system solvency, systems transformation, new federal policies and changes. And I realize that seems very big, but as we were trying to construct a budget that responded to all these different variables, it just became kind of untenable to explain all the different scenarios that are popping around, and they're popping around so quickly. So yeah, that's it.
Great. So we have your ups and downs.
Perfect.
And in addition to that, what you're saying is you have a language change. We'll see how it compares with what's already in the budget.
Oh, it's the same thing.
It's the same thing. Okay, so that's great. So, but you would like more ahead people. If you could.
We'll send you.
Maybe send me something in writing, so we.
Yes, we
figure out
will
what it is.
absolutely send
Your
you something.
additional asks are related to anything else. And so John and then we really have to stop because we have a public hearing to figure out.
I'm done.
Figure it out.
I can
I
ask the
want to say
question.
that we didn't get into a head at all in this conversation. I would ask that we have them come back and see what this transformation, or this transition, it's more transition. What One Care, I mean, I don't know. I don't think a lot of people understand what One Care did.
Yeah.
I think most of us don't understand what a head's gonna do. And how does that impact all of the, the structure?
And so the healthcare committee is going to take up a lot of this, and I'm imagining that they've discussed or you've all discussed ahead in healthcare. I don't know if we can get them back. These guys we're fully booked next week, and then it's not till after town meetings break. So whether we're going to be able to get them in to talk about it before the budget, or whether we have to rely on the healthcare committee, I don't know yet, but I understand what you're saying.
So we have to figure out how it's gonna cost, if you're gonna have all, there was.
They wouldn't necessarily need to come back for like 2 hours, but I think a long period of time, they'll understand what a head is.
Yeah, but it's not going to be till after, I
think that's fine. We don't need to come
So, we may try to get you back in March for one specific topic. And try not to stray, that's the problem. So much to talk about. Thank you all very much.
Thank you.
Yeah. Committee, we are going to be.
Nice to meet you.
45 in room 11, so I'll get there at 4:40, please, so we can be set.
I was late coming in.
Also, let's check with her, but let's go up.
Lucian.
Oh, really? Okay, yeah, no, yeah.